Hi everybody, and welcome to our module on common emergencies. We'll start by talking about heat illnesses, which are a group of disorders that all involve a failure of thermoregulation. So your body has many mechanisms to keep your temperature normal even when the outside temperature is warm, but can only handle so much outside temperature. So during extreme heat or humidity, the body temperature can rise, thermoregulation fails, and that can lead to clinical syndromes of the heat illnesses. And although the heat illnesses can occur in many demographics, they often occur in athletes who are exercising in hot weather, and people that practice sports medicine encounter these frequently. We'll start by talking about heat cramps, which are the mildest form of heat illness. A heat cramp simply means an exercise-associated muscle cramp. So someone who is exercising for a prolonged period of time and develops a cramp, that's called a heat cramp. And in fact, the term heat cramp is probably a misnomer. There's no definite evidence that these cramps are related to body temperature, and most athletes who develop heat cramps do not have an elevated body temperature. Nevertheless, this is the name that has been established for exercise-associated muscle cramps, and the treatment is fairly basic. Patients should be advised to hydrate and replace any sodium losses, which they can do with a sports drink, and sometimes stretching and massaging the muscle helps. Heat syncope, as the name implies, refers to syncope in patients who are exposed to high temperatures. Importantly, patients with heat syncope have a normal or only mildly increased body temperature. If someone collapses in the setting of high temperatures and their body temperature is very high, then they have something called heat injury, which we'll talk about later. But if there is a collapse and the body temperature is normal or only a little bit increased, then that's what we call heat syncope. There are exertional and non-exertional forms of heat syncope, and we'll talk about the differences between these in just a minute. And the treatment is with cooling and rehydration. And in the neurology section, I have an entire video on syncope where I talk about the workup of syncope. And I just want to point out here that in order to diagnose a patient with heat syncope, you still have to exclude other causes of syncope. So if someone collapses on a hot day, they still need an EKG and an exam and other elements that I talk about in the workup of syncope. Only when those other elements don't turn up a cause and the patient fainted in the setting of very high outside temperatures do you make the diagnosis of heat syncope. Exertional heat syncope occurs at the cessation of exercise activity, and the word cessation is very important. Syncope that occurs during exercise is a red flag for cardiac disease that I talk about in detail in the video on syncope. But in patients who have just finished exercising and they're in the process of cooling down, when patients have syncope in that setting, that's consistent with heat syncope. This is common in individuals who participate in endurance exercise like marathons. You may have seen people who collapse at the end of a marathon. That's often from heat syncope. And there are two mechanisms behind heat syncope. The first one is as you exercise, there's vasodilation in your skin as your body tries to dissipate heat. In addition, while you're exercising, when you contract your muscles, that puts pressure on veins, which pushes blood back to the heart. So when you stop exercising, there's an abrupt loss of this muscle pressure on veins, and that can cause a decrease in venous return. And when the venous return falls, that lowers the cardiac output. And if you also have ongoing vasodilation from exercise, this is a setup for syncope. Non-exertional heat syncope is syncope when exposed to high temperatures that does not occur at the cessation of exercise. And this form of heat syncope is simply related to the diffuse vasodilation that occurs as your body tries to dissipate heat. In some individuals, this leads to a significant fall in blood pressure, and that can lead to syncope. Heat exhaustion refers to the inability to continue to exercise in the heat. This is something that can occur in athletes who are exercising on a hot day. In heat exhaustion, the temperature is usually elevated, but importantly, it's usually not above 104 degrees. It's usually in the range of 101 to 104. When your temperature gets above 104, that's what can lead to heat injury and heat stroke, which we'll talk about in just a minute. The cause of heat exhaustion is usually inadequate cardiac output. As athletes sweat, they lose circulating volume, and this can cause the cardiac output to fall. The peripheral vasodilation that occurs when you exercise in a hot environment can also contribute. Importantly, however, in heat exhaustion, there's an absence of neurologic dysfunction. If there's evidence of neurologic dysfunction, like confusion, then that suggests the patient has heat injury or heat stroke, which we'll talk about on the next slide. And the treatment for heat exhaustion is with cooling and rehydration. Heat injury is the most serious form of heat illness. Heat injury refers to organ damage caused by hyperthermia, and it usually presents as collapse during exercise, and the patient will have a very high body temperature, usually over 104 degrees. And there are many different organs that can be damaged in heat injury. This could be the kidneys, leading to renal failure. Heat injury can cause ARDS or DIC, And if heat injury causes CNS dysfunction, then that's called heat stroke, which is a special form of heat injury that we'll talk about now. So heat stroke presents as collapse during exercise. It requires a body temperature over 104 degrees, and there has to be evidence of central nervous system dysfunction. This is what makes it heat stroke and not some other cause of heat injury. Usually the evidence of central nervous system dysfunction is encephalopathy, meaning the patient is confused and disoriented. And since heat stroke is just one form of heat illness, patients with heat stroke can have heat injury to other organs besides the brain. Exertional heat stroke occurs during exercise. It often occurs in young, healthy athletes who have simply pushed themselves way too far. And the presentation of collapse during exercise is a red flag for cardiac syncope. However, patients with exertional heat stroke will have a very high body temperature and evidence of neurologic dysfunction, and those things are not usually seen in patients with cardiac syncope. Non-exertional heat stroke usually affects older patients, often over the age of 70, and many of these patients have an impaired ability to thermoregulate related to chronic disease. They often have underlying cardiovascular or neurologic disease. Many patients with non-exertional heat stroke have obesity or physical disability, and they're often on medications that impair the autonomic nervous system, things like beta blockers and anticholinergics. The treatment of all forms of heat injury, including heat stroke, involves cooling, and we'll talk in a minute about special cooling techniques used in the setting of very high body temperatures like over 104 degrees. Patients also need fluid and electrolyte replacement, and then they can need specific treatment for whatever organs have been involved in the heat injury. This could mean treatment for renal failure, ARDS, DIC, or what have you. So there are a number of ways that you can cool patients who have heat injury or other forms of heat illness. The simplest thing to do is to place the patient in a cool room and give them cold water to drink and cold water compresses. But for patients who have life-threatening forms of heat illness like heat stroke, more aggressive forms of cooling are used. One technique is called evaporative therapy. This is a very effective treatment for hyperthermia. In evaporative therapy, the patient is disrobed and they're sprayed with a lukewarm water mist, and then fans are blown over the moist skin. And as the water evaporates, it takes heat with it, and this can cool the body temperature very quickly. This is used in heat injury and heat stroke. You also can immerse the patient in cold water. This is not always available, but when it is, it's a very effective way of lowering the body temperature quickly. You also have to be careful when you do this because the vessels in the skin will vasoconstrict. That can raise the blood pressure and the afterload on the heart, and so cold water immersion is potentially dangerous to elderly patients. Now let's switch gears and go in the other direction and talk about hypothermia. The definition of hypothermia is a body temperature below 95 degrees Fahrenheit or 35 degrees Celsius. And this can be caused by exposure to a cold environment, like exposure to cold outdoor air or cold water. There are also a number of medical causes of hypothermia. Two of the big ones are sepsis and hypothyroidism. Both of these conditions can lower the body temperature. We classify hypothermia as mild, moderate, or severe based on the body temperature. Mild hypothermia leads to shivering and tachycardia. Patients can breathe faster, and muscles can become immobile, and that can lead to ataxia and dysarthria. In moderate hypothermia, which is below 90 degrees Fahrenheit, CNS depression begins to occur, and so when this happens, patients can develop bradycardia and hypoventilation, and often they are not shivering. The absence of shivering in someone who is hypothermic is an ominous finding. And then finally, severe hypothermia is below 82 degrees Fahrenheit. When this happens, the hemodynamic systems of the body become unstable. Patients can develop fluctuations of blood pressure and pulse. They can have severe CNS depression. Coma, arrhythmias, and death can also occur. The treatment for all forms of hypothermia is to warm the patient. The simplest way to do this is called passive external warming. This is used only in mild hypothermia. This involves removing wet clothing and giving the patient blankets to limit heat loss. The patient will continue to shiver to generate heat, and so the shivering coupled with the blankets leads to a rise in body temperature. The next level up in warming techniques is called active external warming. This is used in moderate to severe hypothermia, and the idea here is to use things like warm blankets and heating pads to actively warm the patient. And then the most aggressive way to warm a patient is called active internal warming. This is used only in severe hypothermia. This involves internal measures to warm the body. This is things like warmed oxygen, heated IV infusions, and in severe cases of hypothermia, you can even irrigate the peritoneal and pleural cavities with warm fluids to raise the body temperature. Cold injuries commonly occur, especially in the extremities when the body temperature gets low. There are a number of different cold injuries that you may see in the emergency room. One of the most serious ones is frostbite. This refers to freezing and necrosis of tissue, but there are other cold injuries as well. Pernio, which we'll talk about in a minute, is a reversible skin condition from cold exposure. Trench foot happens when the feet are exposed to wet and cold conditions. And then frostnip, which often precedes frostbite, refers to paresthesias due to cold exposure that go away with warming. Pernio is a skin condition that occurs when fingers and toes are exposed to the cold. It's also referred to as the presence of chilblains. A blain is an inflammatory swelling or sore, so a chilblain is a blain that occurs because of chill temperatures. Pernio is caused by inflammation of small blood vessels in the skin. These develop as a reaction to repeated exposure to environments that are damp and cold. This is a picture of pernio on the screen here. It refers to painful red patches. They usually develop on the hands and feet, especially in the toes and fingers. And when the body temperature returns to normal and the skin is kept dry, these will resolve over weeks. Trench foot gets its name because it's a condition of the feet that used to occur in soldiers in trenches during times of war. It's caused by exposure to dampness and cold, and it does not require freezing temperatures, but the feet have to be repeatedly kept wet and at a cool temperature. In this setting, there's vasoconstriction from the cold, and capillaries eventually break down, and there's tissue loss, and the feet become painful and sometimes red. This is a picture of trench foot on the screen here. There are red patches here. The feet are wrinkled from exposure to damp conditions. Frostnip is a condition that often precedes frostbite, as I mentioned before. Frostnip happens when blood vessels in the extremities, usually the fingers or toes, become constricted, and this causes numbness, pain, and tingling. The skin can become pale or red, but it retains its normal texture, and these symptoms usually resolve immediately when you warm up the hands or feet. Frostbite is one of the most serious consequences of hypothermia. Frostbite refers to freezing and necrosis of tissue. It usually occurs in the fingers and toes, and it often leads to the need for amputation of fingers or toes. Patients with frostbite have a severe loss of blood flow because of hypothermia. This makes the hands and feet stiff and clumsy. Patients with frostbite lose sensation in their fingers or toes from the cold temperatures, and the skin can begin to change colors. It can become red or white or gray or bluish. This is a picture of frostbite on the screen here. You can see patches where it's red and patches where it's white. The skin in patients with frostbite has a distinctive feel when you touch it. It's very hard or waxy. If you get to see patients with frostbite in the emergency room, make sure you feel their fingers and toes because you won't forget what it feels like when there's frostbite of the extremities. In severe cases, bulla can occur with clear or bloody fluid. There's presence of a bulla in this example on the screen here. And in patients who have severe, long-standing forms of frostbite, they can have eschar formation, which means black necrotic tissue develop in their fingers or toes. So here's a summary slide of some of the changes that can happen in the hands and feet when patients are exposed to the cold. Remember that the main problem in frostnip is neurologic symptoms like paresthesias. The skin can become red, but there's no swelling and normal texture. And frostnip is a relatively benign condition that's reversible. It often precedes the development of frostbite. When frostbite is superficial, that's when you can see red to pale skin. There can be swelling from necrosis. The skin gets that hard, waxy feeling to it. And when the frostbite looks like this and it's superficial, the deep tissues usually remain intact. When frostbite becomes more severe, that's when blue, splotchy skin can develop, like shown in this picture on the screen here. The fingers can become numb, blisters are possible, and when the frostbite's severe like this, that's when there's usually deep tissue loss that often leads to a need for amputation. The diagnosis of frostbite is usually a clinical diagnosis made by examining the patient's hands and feet. But you can use a nuclear medicine test called a bone scan to determine how severe the frostbite is. A bone scan involves injecting a radioactive substance called technetium-99, which functions as a tracer, and it gets taken up by viable tissue. So if there is no tracer uptake, then that means the tissue is not viable. If you look at this bone scan of a foot on the screen, you can see that there's darkness and tracer uptake everywhere except the big toe right here. That means that the big toe is dead and not viable, and this can help to determine prognosis for the patient and also to make decisions about whether or not to perform amputation. Besides amputation, other treatments for frostbite are external warming. Tissue plasminogen activator or heparin can be administered because there are often blood clots that form in the cold extremities, so these drugs will break down those blood clots and cause blood flow to be restored. And then there's a vasodilator that's been used in pulmonary arterial hypertension called iloprost, and there is some clinical trial data showing that infusion of this drug into patients with frostbite can improve outcomes by causing vasodilation of the extremities and increasing blood flow to the areas of the body with frostbite. Let's talk briefly about electrical injuries. Electrical injuries are caused by electrical current. So this could be from a lightning strike, an electrical workplace injury. It could even be by someone who is attacked with an electrical weapon like a taser. And electricity is directly toxic to tissues. It also can generate heat, and so that can lead to heat forms of injury. So electrical injuries can cause the heart to go into dangerous arrhythmias like ventricular tachycardia, and that's one of the ways that you can die from an electrical injury. The heat from the electricity can cause burns, and electricity can also damage muscles, causing rhabdomyolysis. And when electrical injuries affect the brain, that can lead to loss of consciousness and weakness and amnesia. And there's no specific treatment for electrical injuries. The treatment is supportive. Usually the electrical damage occurs very quickly and then the electricity is cut off. So when you're evaluating the patient, your role is mainly to identify these types of injuries and treat what you find. Let's talk about puncture wounds. A puncture wound is a penetrating injury caused by a sharp object. Puncture wounds are very common in the feet, like in this picture here, if someone steps on a nail or a piece of glass. There's a risk of infection with a puncture wound. These injuries can lead to cellulitis or even osteomyelitis. Common bacteria, especially when a puncture wound causes osteomyelitis on the foot, are Staph aureus and Pseudomonas. The treatment is to debride the wound, and then antibiotics are given, but only if there's evidence of infection. If it's a clean puncture wound, we do not routinely give antibiotics for prophylaxis. The most important thing to consider when managing patients with puncture wounds is the tetanus immunization status of the patient. It is possible to contract tetanus from a puncture wound, especially wounds involving dirty objects like rusty old nails. If the patient has a clean minor puncture wound, then you should immunize them against tetanus if their last tetanus dose was given 10 or more years ago. If, however, the wound is dirty or severe, then the patient should be immunized for tetanus if their last dose was more than 5 years ago, and then also patients with dirty or severe wounds should receive tetanus immune globulin. These are antibodies against the tetanus bacteria that provide passive immunization. Let's talk about bite injuries. The vast majority of bite injuries are from animals. Most of them are from dogs. And when a dog bites you, you can be exposed to Pasteurella, which is a gram-negative bacteria, Staph and Strep, which are gram-positive bacteria, and also anaerobes. And so because of all the different bacteria that can potentially cause infections after a bite, treatment is usually with broad-spectrum antibiotics, and we'll talk about that in a minute. Human bites are less common than animal bites, but human bites can cause infection with Staph and Strep, also with Eikenella, which is a gram-negative anaerobe, and also with a number of anaerobes that are found in the mouth like Fusobacterium, Peptostreptococcus, and Prevotella. And so just like with animal bites, there are gram-positive, gram-negative, and anaerobic bacteria that can cause infection after a human bite, so the treatment is going to be with broad-spectrum antibiotics. The first thing to do when treating a patient with a bite wound is to clean the wound and debride it. Beyond this, most bite wounds are closed by secondary intention, meaning sutures are not used to close the wound. You can, in some cases, close large bite wounds by primary intention using stitches, but this is only in certain special circumstances. The wound has to be fresh, it has to be less than 12 hours old, there has to be no evidence of infection, and the wound can't be on the hands or feet. Bite wounds on the hands or feet are very common, and they're very prone to infection, and when you close them by primary intention, they almost always become infected, so they're normally left open and allowed to heal by secondary intention. As I mentioned earlier, antibiotics are used in the treatment of bite wounds. The drug that is usually used is amoxicillin clavulanate, which is also known as Augmentin. It has good coverage against gram-positives, gram-negatives, and anaerobes. All infected wounds have to be treated with antibiotics, so these are wounds that might have pus or spreading redness from the wound. And then many uninfected wounds are also treated with antibiotics unless the wound is thought to be very low risk for infection and a minor injury. And you'll see on your rotations that in some cases where the bite is very superficial and clean, your attendings may choose not to treat with antibiotics. For all animal bites, you have to consider tetanus and rabies. A tetanus vaccination should be given if the last dose was more than 10 years ago. And if there's a possibility that the animal bite may have led to rabies exposure, then rabies prophylaxis is indicated. So let's talk about that now. So rabies is a viral disease that is acquired from an animal bite or scratch. Rabies develops months after exposure to the virus, and it's a central nervous system infection that leads to encephalitis, coma, and ultimately death. There's a very poor prognosis once rabies has been contracted. So because the prognosis is so poor, post-exposure prophylaxis is very important. Anyone who may have been exposed to rabies through an animal bite or an animal scratch has to receive the rabies vaccine and also needs to receive rabies immunoglobulin. And the idea is that the vaccine will cause an immune response and the production of antibodies, but until those antibodies are produced, the immunoglobulin will be infused and provide passive immunization against the virus. So who should get post-exposure prophylaxis? Well, the high-risk exposures that definitely need rabies post-exposure prophylaxis are scratches or bites from a wild animal, especially from a bat. Bats are very high risk for transmitting rabies. Also animals like foxes, raccoons, and skunks. Usually post-exposure prophylaxis is not given if someone is bitten by a pet dog or cat. And then there are some wild animals that are considered low risk for transmission of rabies. Bites or scratches from these animals do not require post-exposure prophylaxis. Some of these animals are squirrels, chipmunks, mice, rats, and rabbits. And that concludes our module on common emergencies.